Hi, this is an in-service on hypertension in pregnancy and postpartum. I put this together for newer staff or staff that work mother-baby because you'll be taking care of patients with higher blood pressures also. And also I thought it was a good way to kind of let you know why in labor we do what we do for hypertension. My name's Donna Grothwell, and I've worked at Elkhart General for 36 years now, all in the maternity department. I've worked in management, in education. I also work for Southwestern Michigan College and do clinicals on our floor, usually one day a week. So you'll see me in that role too. So I do have a love for teaching, and um, two of the things I most like to talk about are hypertension in pregnancy, and then I also have a big love for fetal monitoring. So there's two reasons why I put this together. Is first of all, of course, as nurses, we want to give the best possible care to our patients, and so all the knowledge that we can soak up is good, so that we can provide that good care. The other reason is that across the United States, there's been a hard look at the maternal mortality rate. In this slide, you can see that the United States from 1990 up to 2015, and I think it's still the case here in 2020, is that our maternal mortality rate has increased instead of decreased like other developed countries in the world, and it's increased quite a bit. So, like I said, there's a lot of attention that's been focused on that. So then if we just look at the United States, you can see the different levels of maternal mortality across the state. And the ones in the darker red are states that have the highest mortality rate. So Georgia, I believe, is the highest rate, then Louisiana, and then Indiana comes in third, which is certainly a place that you don't want to be. And if I can call your attention also to the western side, California, Nevada down there, they have the lowest rates, along with, there's a little state up here that I'm not even going to try and name at this point. If you look at, this was done in 2016, and you can see that this shows the trend between Indiana and the United States as a whole, and we're twice as high as the rest of the states put together. So the last graph I'm going to show you, and the reason why I mentioned California earlier, is California is in blue on this graph, and then the entire United States is in red. And back in 2006, California had a spike in their maternal mortality rate, and it was recognized as a problem. Probably started off as a small group of people. It involved physicians, nurses, anesthesia, and they wanted to see what they could do to bring that rate down. So they looked at hospitals across California to see, who had the lowest rates, who had the higher rates, and what were the lower rate state or hospitals doing that were different from the hospitals that had the higher ratings. And by doing that and looking at evidence-based care, they developed protocols for the care of patients who were in emergency conditions. So not just hypertension, but postpartum hemorrhage, shoulder dystocia, those kind of things. So then you can see after they got their protocols in place and they put them in place across the state, their numbers really sharply declined. And by 2012, they were at their lowest of 6.2. And they had a little bit of an increase in 13, but their rate continues to be the lowest in the country. And so what they did is they developed a collaboration, and this became, bigger and bigger. And a lot of the work was done at Stanford University, but they created the California Maternal Quality Care Collaboration. and they included all their protocols. They put them out for everyone to see. It didn't cost you to get those protocols, and so states across the country now are replicating these protocols because they obviously are working. Because California decreased their rate by 55% from 2006 to 2013, which is a huge decrease. So they're also known as CMQCC, and they have a website, cmqcc.org. And if you're interested, they've got a lot of information on there, and we are following and have been following their protocols for several years now. So who are the patients that are at higher risk for morbidity and mortality? And African American women are 3 to 4 times more likely to have complications and suffer morbidity or mortality during childbirth than Caucasian women. Women who live in lower socioeconomic status or lower middle class are more likely to have M&M during childbirth and postpartum. Young adolescents are at the highest risk of fatal complications of any age group, and non-English speaking women have a greater chance of M&M during childbirth and postpartum because they don't always understand what's going on, and we don't always understand, what they're, they can't speak to us and let us, they can speak to us through translation, but that communication can still break down. So 5 to 10% of all pregnancies are complicated by hypertension. You can see the hospitalization numbers have increased from 528 to 912 per 10,000 patients who are pregnant since 1993. It started off at the 528 and then has risen to the 912. Having done this for a long time, I can remember early in my career that we didn't see many hypertension or patients who come in with hypertension that needed to be induced or those kind of things. I don't think back then we were doing all that we do now based on what blood pressures we see, but it certainly has changed. 50,000 maternal deaths per year occur due to complications of hypertension worldwide, and that's a lot of women who die because of this. The complications that we see with mom are placental abruption, seizures, stroke, coagulopathy, and cardiac, hepatic, or renal failure. And we'll talk more about that as we go along. Also to know is that maternal complications may not be seen until postpartum up to 6 weeks after delivery. And we know these patients are more likely to be assessed in the emergency room. But some women show no signs at all until after they deliver. So with mom, they can suffer a placental abruption while they're pregnant, which will cause blood loss and can cause harm to the baby. And they can develop DIC, cerebral hemorrhage, stroke, hepatic, renal, or cardiac failure. These patients are 4 times more likely to have a stroke now or later in life. That's a pretty scary number to me. And the leading causes of maternal death include complications from the abruptions, from liver rupture, and eclampsia. And 1 of 4 women who die during pregnancy or after delivery die from complications of preeclampsia or eclampsia. Now this is kind of a repeat of what I just said, but in the bottom there it does talk about the baby. These babies typically have IUGR, intrauterine growth restriction, or they're small for gestational age because there's not as great of a blood flow from mom to baby through the placenta, so they're not getting all those, all the oxygen they need, all the nutrients that they need. Many times they're born premature because mom needs to be delivered earlier. They have low APGARs, they can suffer from seizures, and 10% of early neonatal deaths were born to a mom who had hypertension. So there are different classifications of hypertension. Women fall into one of these categories, but these classifications are based on what gestational age they were at the onset of the hypertension, or if they have the presence or absence of other symptoms that we'll be going through. The first classification, which we see probably the most, is gestational hypertension. Um, it used to be called pregnancy-induced hypertension, or PIH, but that's an old term now. But this hypertension begins after 20 weeks of pregnancy. Prior to that, they had normal blood pressures. They have no proteinuria, and they don't have severe features, which we'll talk about here in a little bit. And 25% of these women will go on to develop preeclampsia. So in the second classification, there's two different ones that are very similar to each other. So we got a 2A and a 2B. But this is preeclampsia, and it's a new onset of hypertension after 20 weeks of pregnancy. So again, before 20 weeks, they were good. And this can occur up to 6 weeks postpartum, whereas the gestational hypertension usually goes away fairly soon after delivery. What makes this different is that not only do you need to see the hypertension, but we also look for proteinuria, or they have hypertension and one or more of the severe features. And it's called preeclampsia with severe features. So those features are blood pressures over 159 and or a diastolic pressure greater than 109. Thrombocytopenia, their platelets are less than 100,000. They have impaired liver function, and we see that on their CMP through their SGOT and SGPT. Their serum creatinine is greater than 1.1, and we also see that in the CMP. They may have pulmonary edema, or they have new onset of cerebral or visual disturbances, and they have this persistent epigastric pain. So 2B then is eclampsia, and these are women that have all, the signs of preeclampsia, but what's different is they also have a grand mal seizure with no prior neurologic problems. They don't, they're not epileptic. They're not, they don't have seizures. They didn't have seizures before this. 50% of these seizures occur in the antepartum period, so before they deliver, and then 50% of them occur in the postpartum period. And 16% of those women have these seizures later than 2 days after delivery. The next classification is chronic hypertension, and this hypertension is present and observable before pregnancy or prior to 20 weeks of gestation. And this will persist beyond 12 weeks postpartum, and they are at an increased chance of developing preeclampsia, and this pregnancy is in a higher risk of placental abruption. And then the fourth classification are patients who have chronic hypertension with superimposed preeclampsia, and this is associated with some adverse events. There's one other classification or one other thing they can develop, and that's called the HELP syndrome. And at the bottom of the slide, you'll see what the HELP stands for. And H is the hemolysis of red blood cells. You might see on the report that there are Burr cells or schistocytes, and those are just red blood cells that are not, they don't look like the typical red blood cell. They have, there's pieces of them that are, hanging off the cell or whatever. They also may have an elevated LDH of greater than 600, and because of the extra or the red blood cells that are damaged, they can also get hyperbilirubinemia because um, those red blood cells aren't able to transport the bili out of the body like they usually do. The EL stands for elevated liver enzymes, and that would be the SGOT and SGPT. And then the LP is low platelets, lower than 100,000. So this diagnosis is based on these specific labs. And 5 to 10% then of women with preeclampsia can develop HELP. It's a variant of preeclampsia, and it does have severe features, and it is a severe complication. Unfortunately, we don't see it real often, but every once in a while we do. And this will affect multi-organs and will cause damage. And women who have that can die from DIC, pulmonary edema, renal failure, or stroke. So these patients, excuse me, need immediate treatment and urgent delivery if they're still pregnant. And these women a lot of times end up in critical care after the delivery of their baby. Problem with HELP is that the signs and symptoms are pretty nonspecific. Their blood pressure may only be mildly elevated, but there are certain signs that can be looked for with this, and this would be that epigastric pain in the upper right abdomen. It's just a constant pain, and it doesn't go away. And if you add nausea and vomiting onto that, then you kind of put all those things together and do the labs and see what you have. This endothelial cell damage that they get can lead to fibrin deposits and adherence of platelets in the blood vessels. And again, those RBCs are damaged. They pass through narrow blood vessels and they get damaged even more. So the red blood cells and the platelets are decreasing, and like I said, they can develop hyperbilirubinemia. So these type of patients will certainly be cared for by labor nurses until they become stable again. So just as an FYI, as long as I can remember, they've been trying to figure out what actually causes this. There are a lot of theories. They think it has to do with genetics. But what's interesting to me is that this, at the time that that the pregnancy begins and the placenta is being developed and adhering to the uterus, and it takes a couple of weeks before it takes over total control of providing the baby with what it needs, is that those very early weeks, it's predetermined at that time by the way the placenta implants as to whether this woman, has will have preeclampsia or not. So one of the things they do look at is what they're trying to figure out is if they can develop testing to look for specific biomarkers. And so I see, someday, maybe 5-10 years from now, where they will do testing early in pregnancy to see if certain biomarkers are present and that this pregnancy needs, lots of extra care and keeping an eye on the mom and the baby. They used to put these patients to bed. They restricted their salt, put them on diuretics, or used heparin, and research does not support that, so they're not doing that. They may give them calcium supplements, which decreases the smooth muscle contractility and will increase vasodilation. And they also will use the low-dose aspirin. which they start in the late first trimester, and they will use this on women who are at risk, usually women who have had this with a prior pregnancy or have a lot of risk factors for hypertension. So early detection is important. Unfortunately, some patients don't get prenatal care, or they get prenatal care late. And, those are the women that you have to worry, more about. So normally in pregnancy, there is systemic vasodilation. There is up to a 50% increase in plasma volume. There's more red blood cells, so then the hematocrit is higher. There's hemodilution, which makes the hemoglobin go down, and that's why more pregnant women get this physiologic anemia during their pregnancy. So there's increase in their cardiac output, the stroke volume, there's a little bit of an increase in their heart rate, and they need a little more, might need a little more oxygen. And there's specifically a decrease in systemic vascular resistance. Again, the body, wants to provide as much blood to the baby and to mom as it can. They might have a slight decrease in their blood pressure. Their fibrinolytic activity is decreased. Their platelet counts, the bleeding time is normal, and they, pregnant women do get edema. But when edema gets severe, it's like, they're swollen in their face and their hands and their legs, and it's usually pitting edema. What preeclampsia, though, does is it causes a much smaller increase in blood volume, and plasma volume may see little or no change. They have increased peripheral vascular resistance and vasospasms. The fibrinolytic activity is increased, platelets decrease, and their bleeding time is prolonged. So there's, it affects many organs in the body. And, when you're talking about your brain and your kidneys and your heart and the placenta, those are pretty important things. So with the renal kidney issues, they can be oliguric, they have proteinuria, they might even go into acute renal failure. They can't metabolize drugs and excrete them as well. Proteinuria is the way it's defined is that if they have a 24-hour urine done and there is 300 or more milligrams per liter of protein in the urine, then that would be, that would they could diagnose the proteinuria at that time. We've seen women who have had, 1,500 or 2,000 milligrams per liter. So those numbers can get pretty high sometime. So the 24-hour urine, of course, takes 24 hours and usually more to have it, analyzed in the lab and, to get it to lab and all that kind of thing. And there are times when we can't wait that long. So we'll do a test called the urine protein creatinine ratio. And we've only used this test for the last couple of years. It's become more of a standard of care to use. And if that number is 0.3 milligrams per deciliter or greater, then proteinuria can also be diagnosed. We can dipstick their urine, and we still do, especially when it's showing a really high number, then we can say, well, their chances are good of having the proteinuria, but it's really not reliable because at different times of the day, women are going to have different levels of protein in their urine. So if they come into labor, we're going to check on their renal status, and that's when we're looking at the creatinine, the BUN, and then this total protein creatinine ratio. and then they will also look sometimes at uric acid. Central nervous system wise, they have increased irritability, and that's where you get the headaches, where they get hyperreflexic or have clonus. They might have an alteration in their level of consciousness or the seizures. And so these complications, can turn into cerebral edema, cerebral hemorrhage, or stroke. So pretty serious. So with the placenta itself, it can cause an abruption in the placenta, uh, but uh, but most of the time there's this decreased uteroplacental perfusion where it's just not getting perfused with what it needs. The liver can also get involved, and they can go into liver failure. The liver can actually rupture in an extremely ill patient, and so that's why we're looking at their SGOT and SGPT. And if those are high, there's other tests that they'll do to check on the liver. Thrombocytopenia then, less than 100,000. This platelet destruction occurs. The lifespan of the placenta is less, and just all the things that we just talked about. If their labs show that the platelets are less than 100,000, then they'll go on to order PT, PTT, fibrinogen, FDP to check more on their bleeding times. And let's see, cardiovascular and pulmonary wise, they can get into heart issues. They can have an MI. They can get pulmonary edema. And so again, not good for the heart and lungs. And it's been shown that women who have this later in life have a higher chance of having cardiovascular issues. So there's a whole lot of risk factors for hypertension in pregnancy or postpartum. It's most often seen with a first pregnancy, shown in the very young or the older women. It could be a first pregnancy with a new partner. They've had a history of preeclampsia with the severe features. Maybe their moms or sisters had high blood pressure during their pregnancies. If we have more than one baby in the uterus, that increases their risk. And then you can see all the pre-existing medical factors that can also put them at risk. And, the chronic hypertension, if they have gestational diabetes, or did they have type 1 or type 2 diabetes before this, and then the higher BMI patients. So a couple things to know as you are taking care of a woman who it was stable enough to become a postpartum patient is, first of all, you got to look at the way you're taking their blood pressure. Now, usually by the time you see them, they'll have the proper size cuff in the room, but the cuff should cover 80% of their upper arm. If it's too small, we're going to get false highs, and if it's too large, we're going to get false low readings. They need to be in a semi-Fowler's position, and laying in bed without their feet crossed. We used to take their blood pressures on their left side. Well, you're going to get a better blood pressure when they're on their left side, but that's not a true indication of what a patient normally is doing. They're not going to be laying on their left side all the time. Before you take the blood pressure, let them rest for 5 to 10 minutes. Maybe you have them, get in bed, lay down, and just talk to them for a little bit, and then go ahead and take their blood pressure. Patients shouldn't be talking during a reading, and if they are sitting at the side of the bed, their feet need to be on the floor and uncrossed. So if you do get a blood pressure over 140 over 90, I put the repeat Q15 minutes. We'll usually do that when they're pregnant and in triage, and we're evaluating them. Based on what their blood pressures have been after delivery, it's probably not as important to do Q15. But you do want to let your charge nurse know, and take direction from her. If you get a blood pressure over 160 systolic, or I should say over 159 systolic, and or a diastolic greater than 105, 110, then it needs to be a priority to you to repeat this blood pressure in 10 minutes. And if it's still this elevated, then we will contact the physician. We'll look at, does she have severe features or not? And then they'll decide about moving on to some antihypertensives. These women should have their lung sounds listened to well, even after delivery, just to make sure they're not developing pulmonary edema. If they do have edema in their legs, is it pitting? I always ask the patient, does it look better to, how does it look compared to yesterday, especially if I haven't taken care of them the day before. Deep tendon reflexes, we usually do a patellar reflex. And if you've not done them before or need help with them, be sure and ask somebody. But normally what we'll do is we'll have them bend their knee, and I put my arm underneath their knee and ask them to relax so that the weight of their leg is in my arm. And sometimes it's hard for them, so you just need to help them relax a little bit, and then just strike that patellar reflex. And it could be you might not get anything, or you could get a 1+, 2+, 3+, or 4+. And with 4+, you just barely touch their knee, and their foot practically kicks you in the face. Usually the DTRs we use just to see, just to compare them to further DTRs, because they could be somebody who has a brisk reflex to begin with. Clonus then is done in their foot, and we have them straighten out their legs, and you put your hand on the bottom of their foot, kind of with your fingers pointing up to the sky, supporting their foot, and then you just gently push back or push the foot towards the head, and you see if there's any response to that. And sometimes you can feel what are just like little beats back at you. Until you really feel it, sometimes it's hard to know what you're going to feel. But, do they have no clonus? Do they have 1 beat, 2 beats, or more? Again, we might do the dipstick for the urine, especially if we can't get a urine for PCR, and they don't want to be doing that, every 2 hours or 4 hours, so we might do dipsticks in between. If the patient has delivered or they're having vaginal bleeding, then we're going to need to do a straight cath. A clean catch is okay, but it's got to be the kind of patient that's really going to follow your direction and cleaning themselves off, and they need to pee a little bit, stop, go in the cup. And sometimes that's really hard for women to do. And then as you're assessing the patient, especially if their blood pressure's up, but if they say we're on MAG during labor and their blood pressures have been up before, I always ask, are you having any kind of headache right now? Where in your head are you feeling it? Usually this type of headache is a frontal headache, but it's not always there. Do they have any spots, blurriness of their vision? Does light make their eyes hurt? Swelling and epigastric pain, are they feeling any of that? And patients don't know what epigastric pain is. I mean, most of them don't. So you just kind of I always point to my upper right rib cage and ask them if they're having pain there. And sometimes they'll say, well, I'm having some heartburn. But if it's a continuous pain in that area, that would be, positive for epigastric pain. And are they nauseous or vomiting? A few signs of impending eclampsia would be a persistent headache that's progressively getting worse, the blurred vision, epigastric pain. I would add nausea and vomiting to this, and especially if they have an altered mental status. And problems we can see after a seizure include neurologic deficits, and aspiration pneumonia. If a patient's having a seizure, what we want to do at that time is to keep them safe. We're not going to put anything in their mouth. We're going to get them, over to their side if we can, or at least just get the head turned that way, and just support them. And of course, you're going to put an emergency light on and get some help. And we don't see many seizures. Which is good because, I was taught as a young nurse that if we have a patient in the hospital with preeclampsia and then they seize, there's something that we missed along the way. And I can't say that's true of every case, but yeah, you can see other signs before you get to that point. Labs we already talked about. Some doctors do uric acid, some don't. But if the uric acid is increased, it can be associated with renal failure. The LDH or lactate dehydrogenase could be a marker of hemolysis, and if that's elevated, and then we talked about the platelets. There's such a thing as called MUSE, and that's maternal early warning criteria, which we go by, and I'll show you, unfortunately it's a couple slides down, but I'll show you what we look at in this tool. And this is part of the whole CMQCC protocols. But its aim is to standardize care. All our protocols are this way, so that the right treatment is being given every single time. And if you're following a checklist, then you don't, forget what you need to do. And it outlines when consults are needed, that kind of thing. So this is another protocol that we look at. And I couldn't get the entire page on this one sheet, so there'll be a second part here in a second. But you can see what we're looking at. Are they aware? Do they have headaches? What their blood pressure is like? Respirations, O2 sats, and then pain and fetal signs along with urine output. And you can see through the green here, these would be all normal signs that we don't, need to do anything about. But then we get into the worrisome yellow section, and say they're more agitated or confused, drowsy. They do have a headache. They have some nausea and vomiting, some blurred vision. Their blood pressure is 140 to 159, and diastolic is 90 to 105. Their heart rate may be elevated, respirations elevated, O2 sats are below 95%, and it just goes on from there. The category 1, 2, and then 3 for fetal signs is just what the monitor is showing us, and then we put there's categories that we put them into, and then you can see in the bottom their urine output is decreasing. And then we have the severe side, and you can look at those things, but the one thing is that their blood pressure systolic is over 159, over diastolic of 105, heart rate is high, respirations are either real low or high, and so on. So what was at the bottom of that sheet then is what we should be doing depending on what category they fall into. So with the green, there's really nothing different we're going to do. Yellow, we need to be notifying the provider right away. Charge nurse needs to be aware. Doctor needs to come in and do an in-person evaluation. They're going to order some labs. We want to make anesthesia aware. They might consider mag sulfate, maybe some oxygen. And then in the severe section, you can see there's a whole lot of things to do. These patients are definitely a 1-to-1, sometimes a 2-to-1 to get them stable. But they, would get a CT to look at their brain. We're definitely going to be doing mag at this point, and you can see all the other things that we would be doing. We want to rule out pulmonary edema by doing a chest x-ray and listening to their lungs real well. So more on the Muse then. Anytime, and this doesn't pertain just to hypertension, but these are posted, and anytime you have the criteria that's in red, their output is less than 35 cc's an hour for 2 hours. They're agitated, confused, or unresponsive is bad. And if they have the hypertension, they have a headache and shortness of breath, those things need to be communicated to the provider immediately so that they can either come out or come in and assess these patients more closely. The second column then has to do with their blood pressure and vital signs. But if their systolic is less than 90 or greater than 159, if their diastolic is over 105, you can see the numbers for the heart rate, respiratory rate, and if their O2 sats are less than 95%. Any of those things happen within 10 minutes, then we're going to repeat those tests and verify that they're definitely within those ranges. So this is another protocol that we follow, and this has to do with a blood pressure that's greater than 159 over a diastolic that's greater than 104, I guess we can say. It's been repeated within that 15 minutes and it's still elevated. Then we're going to put this into place. And of course, the charge nurse needs to be notified and the provider needs to be notified as soon as possible because these patients then are going to need antihypertensives. There are three main drugs that we use. In the middle column, you can see labetalol, IV push, and then the third column is hydralazine, IV push. The first column would be Procardia, and this is given PO. And we would use that if we don't have IV access and blood pressures are still high, then we want to get something on board. So we'll start with 10 milligrams of the Procardia in the top box. And after 20 minutes, then if there's still no access and blood pressure is still in those high numbers, then we can give them 20 milligrams. And we're doing blood pressures Q10 minutes. And then after another 20 minutes of still up high blood pressures, then we're going to give another 20. But hopefully we're going to have IV access. And, some doctors use the labetalol, some use the hydralazine. Labetalol has fewer side effects, so I would say that probably gets used a little bit more often. But we can start then with 20 milligrams labetalol over 2 minutes. They need blood pressures Q5 and cardiac monitoring, and definitely the charge nurse or labor nurse would be pushing meds, and these would be things that you would observe more, or they may have you get the labetalol or apresiline and give those, but there is definitely should be somebody with you at this point, and that's true of anybody, no matter how long they've been there. It's always good to have an extra pair of hands. So the 20 of labetalol is given. If after 10 minutes after that was given, the blood pressure is still high, then we'll give 40 milligrams over 2 minutes. After another 10 minutes, then we'll give 80 milligrams. And after another 10 minutes, if it's still high, then they will probably move on to the apresiline. And some doctors don't follow every level of this, but this is what's recommended. Hydralazine, you can see those. We're increasing the hydralazine based on what their blood pressures are, and if it's still high, they might go on to the labetalol then, but there should be somebody physician-wise at this time. So here's some more information about the antihypertensives that we used. The protocol says that the meds should be given within 30 to 60 minutes after that second reading has been taken. If they're not showing any severe features, maybe their blood pressure is just elevated, they may or may not give antihypertensives or maybe give them an extra oral dose and won't um, get into the IV medication. So it just, again, depends on how sick they are. Uh, so the first line meds that I talked about were the labetalol and the apresilene IV. Second line would be the Procardia. You can see with labetalol it is contraindicated with somebody who has asthma or heart issues. It does have less side effects, but it can also lower their blood glucose. And some OBs give labetalol during pregnancy, and some don't. The ones that don't give it are afraid they're going to mask some symptoms that we need to know about. And then all docs give labetalol PO after delivery if it's needed in various dosages and doses per day. Some patients end up on both labetalol and Procardia to control their blood pressure. The combination of the two seems to be what they need. So I know you don't work specifically with women on mag sulfate, but just a little information about it and why it's given. It's the drug of choice in the management of preeclampsia to prevent seizure activity. Some people think it's given to help decrease blood pressure, and that's not the primary reason that it's given. Now, secondarily, because it does decrease smooth muscle contractility, it may help to decrease their blood pressure, but that's not the main reason. We want to make sure we've done what we can do to prevent a seizure. It not only works though in the central nervous system, it'll work on the heart. It can slow respirations and it can decrease urine output. It's almost exclusively excreted through the kidneys, and they can become mag toxic if the kidneys are impaired. And so we're keeping an eye out for that, mainly by how much urine they're putting out. An antidote to the mag is calcium gluconate. So if they do get toxic on it, then we can give a gram of this medicine to kind of combat the mag and get them through that toxicity time. You'll see that MAG is a high alert medication. It requires one-to-one nursing while initiating the medication or if the patient's not stable. I'm not going to go through this because you won't be doing this, but we're giving a loading dose, a maintenance dose. We put it on a burette so they don't actually get a bolus of MAG. It's really important that we maintain their fluid balance because these women get extra fluids in their body. And so we want to decrease the chance of pulmonary edema. So we're limiting IV fluids and oral fluids to about 125 cc's an hour. And again, it depends on how sick they are. And these women, when they're getting the loading dose, they do feel they don't feel quite right. They feel very warm. They're flushed. They're diaphoretic, and so on. But those are normal reactions. So nursing takeaways that I want you to think about are that if a patient has had elevated blood pressures, it's important to do a more in-depth assessment after they've been turned over to you. So if their blood pressure's up, you don't have to wait 6 hours or 12 hours to do their next blood pressure. It's okay to stick another one in there, especially if they just still aren't feeling well. We talked about during that assessment, you're asking them whether they have a headache, visual changes, epigastric pain, evaluate the swelling in their hands, feet, and legs. They still need to get up and move around just like everybody else does so that we can prevent blood clot in their legs. If you do get that blood pressure over 159, you need to retake that blood pressure in 10 minutes, let your charge nurse know, and that you're retaking it so that she's aware of a change in condition and can be help and a resource to you. Let's see. Um, if the patient is receiving oral hypertensives, they should be given as close to on time as possible. If one nurse gives it early and the next nurse gives the next dose late, you can see where, it might be another 2 hours of waiting time. And, if we can keep that evenly on board, then it works the best. INOs are very important to continue on mother baby, even if their IV is, they don't have IV fluids or it's been discontinued. The physician will keep an eye on those numbers, especially they want to see that they're, starting to diurese and getting rid of that fluid. Uh, some doctors will write maybe a blood pressure to be done every 4 hours or 8 hours or 12 hours, but make sure that you're assessing as often as what the physician has ordered. If your patient, say, you're doing your nursing business and a patient calls you into the room and says they have a headache, the first thing I'd want to do is put a blood pressure cuff on them. You don't have to wait till it's due again. Or maybe it's not even your patient. You happen to go into a room and they have that same complaint. And let's see. But learn from each, learn from each experience. Listen to what, the nurses around you are talking about as they have these patients on MAG. Listen to your gut when they aren't feeling well and go, spend that extra time assessing them to make sure they're doing okay. And if you ever have any questions, ask people around you, or the best person to go to is the charge nurse, because that alerts her, that something's going on. It's hard when, you find out 2 hours later that somebody's had a blood pressure issue. So that is the end of my presentation. I appreciate you taking the time to look at this because it lasted way longer than I wanted it to, but I think the information is good and it just makes you a more educated, well-rounded nurse to know these things. If you have any questions, please feel free to ask me or send me an email. Ask questions of physicians, of nurses, and they're, you know, people are good at teaching on the floor, so they'll let you know. And then this is references that I used. So the bottom one is that CMQCC information. So thank you very much, and I'm going to be coming at you with some other videos also. Thanks.